All right, welcome everyone. This is Douglas Meridian from ArbiMed Retina. Together with Chris Peebles from Notal Vision, we want to thank you for joining us here today. Our good friend Elizabeth Cifers has a value-packed presentation for us. And what makes her uniquely qualified is that Elizabeth not only has over 30 years of experience in the healthcare industry, but she also has over 13 years of experience serving as a retina practice administrator. So she has certainly lived in our world and experienced it from the front lines, so to speak. So we are going to get started today. There is a Q&A option if you'd like to submit some questions during the webinar. We will leave some time towards the end to get to those. And we also do have a couple survey questions or polls that we're going to have during the presentation. But with that, I'm going to turn the controls over to Elizabeth, and thank you for joining us again.
Thank you, Doug. And I want to thank everyone for taking the time to join me for this presentation today. As Doug said, if you have questions along the way, please submit them using the Q&A box, and I'll answer as many as I can at the end of the webinar. And if there are any questions I don't have time to answer or that are more complex than a straightforward answer, I'll respond to you directly. So before we get into the webinar content, as Doug mentioned, I want to take a poll to find out about your familiarity with the revenue cycle. So Doug's going to get the poll up, but basically you have four answers. A, what's a revenue cycle and why does it need to be managed? B, I know enough to know I need to learn more. C, I have experience, but I like additional information. And D, I'm seasoned in revenue cycle management, but I am continually looking for tips. So go ahead and submit your answers, and when they're done, Doug will pop the results up. How are we doing, Doug? Oh, there we go. All right. So we have people looking for information. That's awesome. I appreciate you sharing, and I think this webinar will touch on everybody and everybody will learn something. So, all righty, let's get going. 2020 has just been quite a year of changes, and so I'm going to address both pre and post COVID-19 challenges in revenue cycle management during the presentation. As Doug said, I've been in this industry for a long time, and I can say with absolute certainty, there is no such thing as perfect. So there's no point in striving for perfect. However, you see practices that are well run, and that just means that they have issues, but they have checks and balances and processes in place to continually monitor for the problems. So as we go through the material today, I want you to think about what well run looks like in your practice. At the end of the webinar, you should have information to be able to perform a high-level revenue cycle assessment, determine the impact the revenue cycle has on cash flow, and identify and prioritize areas that need attention. And we have a lot of information to get to, so let's get started. So as you've guessed by now, revenue cycle management is the act of managing the revenue cycle. And the revenue cycle is all the components that go into getting paid for the services provided. As with any other process, it requires monitoring and checkups. The revenue cycle has both internal and external processes. The internal processes include your patient volume, your payer mix, the provider's capacity and productivity, and the practice has control over the internal processes. The external processes, which include your governmental payers, such as your original Medicare, your TRICARE, Medicaid, commercial payers and patient payments, the practice doesn't have as much control over the external components. And the focus today will be primarily on internal aspects of the revenue cycle. So let's start at the beginning with the front desk and we'll work our way through. So as the first contact with patients, whether you call it front desk staff or receptionists, everyone uses a different term, they have to get it right from the start for the revenue cycle to work correctly. If they fail to obtain and enter the correct information in the practice management system, you get a garbage in, garbage out scenario. And the receptionist role cannot be overstated. While mistakes occur, we want them to be minimized and rare if possible. So every revenue cycle starts with an appointment, and making sure that, especially with new patients, you obtain all of their demographic information, insurance information, to allow for insurance verification before the visit is just critical. And actually verifying insurance for all patients, new and established, is super important as well. As you probably know, many Medicare patients are confused as whether they have original Medicare or Medicare Advantage. They don't know if they're in network or out of network, or if they need a referral. They assume that because their doctor sent them to your practice, you're in network, which isn't always the case. So again, verifying the insurance coverage is one of the easiest ways to create a well-run revenue cycle. Additionally, confirming the patient's address and their phone number and getting their insurance cards at each visit is a simple way of making sure you have the correct information. And to ensure the correct address is on file, ask the patient if they still live at 123 Sesame Street versus saying, is your address the same? People lead busy lives, and unless something just happened, they tend to forget. And I've been guilty of that until I was prompted as well. With the emergence of COVID-19, the desk of the front, the role of the front desk is more critical than ever. If you're gathering your demographic information and your insurance information over the phone and you don't even have a copy to look at, your data entry is just critical and must be correct. Being able to verify the insurance at the time of registration and scheduling streamlines your process and allows errors to be corrected that may go unnoticed in other situations until the clearinghouse flags it or the insurer flags it. Also, collecting your copays and outstanding balances when the patient's in front of you is much easier than having to send a statement. And how you ask for payment makes a huge difference as well. If you have front desk staff that say, do you want to pay or are you going to pay? The patient has an option to say no because the way the question's asked. So you can flip that around into, how do you want to pay, or would you like to pay, which change the semantics, and the expectation is they're going to pay something today. And it's always easier to get it in front of you or when you have them on the phone than to have to send statements out and spend more money. So the next piece of the revenue cycle is your technician. Some people have said, why technician? And I said, because they are starting your documentation. Your documentation is your support for why you're billing what you're billing. With EHR, electronic health records, being able to pull forward a note from the previous visit is one of the best parts about it. It's also one of the parts that will cause you the most problem. You can end up with nonsensical chief complaints, weird histories, strange systems of review that don't even go with anything. And so practice pulling forward can and does cause inaccurate information. So the key is ensuring that you review and edit the data from the previous note. I love the fact that you can pull it forward. You're not starting from scratch. However, if you don't accurately edit, you have a problem. So let's say the last visit, your historical chief complaint for today's visit, they pulled forward and it says, no flashes, but notice more floaters left eye. Patient states she's scheduled to have cataract surgery. So as you go through the chart, you see the patient had cataract surgery 2 months ago. So now the chief complaint's questionable. And the cataract surgery documentation for both eyes is actually already in the chart. So the tech working up the patient pulled the information forward, but didn't take time to edit for today's visit. That's where you start getting into big problems. The workflow changes due to COVID are a wide variety. Practices have chosen to do different things with their techs and their workup and how they've processed, but ultimately you're trying to reduce the amount of contact. So previously, the tech would grab the patient, work them up, pass them into dilating or to the photographer for an OCT or other diagnostic testing, and then on to the provider. Pick up your next patient and so forth. Now, a lot of practices are The tech picks up the patient, they're doing the workup, they're doing the dilation, they're doing all your diagnostic testing, and then passing to the provider. As well, they may just keep the patient in the same room, so there's less contamination moving around, less contact in general. It's just become a complex fashion. But no matter how the interaction occurs, the tech must review their work for accuracy and data entry errors, just as the front desk should. So obviously the provider is your next step in your revenue cycle, and they are responsible to make sure that the documentation by the staff has corrections made to it if needed, additions made to it if it's needed, and the provider then performs and documents exam, the diagnoses, the plan, diagnostic test orders, test interpretations, and when's the patient coming back again? Ultimately, the provider is responsible for all the chart documentation for that date of service. And a common cause of denial is failing to document the services appropriately. So if it was not documented, it was not done. If you send information in, the chart note into an insurance company, or you have an auditor looking at it, if the documentation doesn't support the service, then it didn't happen. I didn't say it really wasn't performed, but they're not going to pay you for it. So you have to have appropriate documentation to fully support the services rendered. Additionally, the provider has to pick your CPT codes, your HCPCS codes, your ICD-10 codes that also support that day's service. The provider needs to sign off on the chart, and the code selection should be complete. One thing I find interesting is people don't realize that the medical record is a legal document of the patient's care. So correcting inaccurate chart documentation is critical not only for the accuracy, but also for the revenue cycle. As I talked about, when the chart contains contradictory information, it calls into question the integrity of the whole document. So if the exam said, the fundus exam stated that subretinal fluid is worsening in both eyes, but the OCT interpretation states that there's a trace of subretinal fluid present, OU. Okay, so which statement is true? That's a problem. If the insurance company now denies the visit and or the OCT, now you have to correct the documentation appropriately with an amended chart record, and you have to send it back in an appeal. All of this takes time and increases the days in AR. And we know it happens. And the misinformation is perpetuated visit after visit. I've been an auditor for a long time. I promise you it does in every practice. So whether you call it pull forward, copy paste, or cloning, it can cause you problems. So you must review the information and make sure it's accurate. As far as the provider, COVID-19 has not had a whole lot of impact on their part of the revenue cycle, aside from introducing telemedicine and the nuances of what they need to document and do for that. But ultimately, the provider is responsible for the chart. With the changes coming in January to E&M on January 1, 2021, it is a Friday, the provider will still be responsible for all the medical record content and should continue to review all the documentation. So the last and largest internal component of the revenue cycle is the billing department. And billers will find all the issues that have occurred from the time the patient checked in or registered all the way through everything. It ends in their lap, and sometimes it's the billing department doesn't like us. No, they just find all the mistakes. So they find the denials, they see the clearinghouse problems, they may see it from keying in information of people doing things incorrectly. And a lot of practices use the biller as the final stopgap for correcting your claim errors before pushing them out to the clearinghouse. So charge posting is equivalent to charge review, and especially with CPT, HCPCS, and ICD-10 codes that are selected by the provider, the biller can ensure that there's no bundling issues, there's no missing modifiers or modifiers on that shouldn't be there, or they have an incorrect diagnosis code, such as it doesn't have the specificity. Retina practices tend to use this process to verify that you're billing the correct drug, the correct eye, and to make sure the NDC code is on the drug. It is always easier to catch coding errors before you've submitted the claim. The impact of COVID-19 on some practices, their billing departments, it's been minimal because they were either already working remotely or part remote, part in-house, or they already had a system in place. For other practices, especially smaller practices, it was a huge impact because now suddenly you have to figure out how to work remotely. You have to get HIPAA compliant work sites. You have to change your process to get the information to the billers and all of that. Fortunately, with billing being highly electronic, it does allow for remote working versus seeing patients where you have to do that face to face. And whether the billers are in the office or they're teleworking, revenue cycle management sequence remains the same. Okay, so achieving a clean claim means that there are no corrections needed from claim submission to payment. This is the sweet spot. This is what you're looking for. So the process moves from posting the charges, submitting to the clearinghouse to the insurer, and finally, yay, the provider receiving payment. If everyone does their job accurately and correctly, this goal is achievable. However, people will make mistakes because you're working with people and people are not perfect. So let's review what happens when the claim isn't clean. The biller's review of the claim is the final internal edit level before it goes out the door. So the first external edit is your submission to the clearinghouse. And the clearinghouse scrubs the claims to find errors before sending them to the insurance company. The billers can retrieve a report and review the errors on that submitted batch. And if there were any, they can correct them and resubmit to the clearinghouse again. When I started in billing, there was no such thing as a clearinghouse. You didn't know that there was a problem till you didn't get paid and you were looking at your document. The clearinghouse would then push the claim based on what information you put in the practice management system for the insurance patient, the patient's insurance, and they'll push it out, and now you wait. And you wait to receive a payment, which is awesome, a denial, not so good, or a request for more information. Realistically, you will have some denials and you will get requests for information. Okay, I'm going to detour for a minute to provide some acronym information for the revenue cycle, especially those who are new or not as versed in it. This is alphabet soup, basically. So the payment, denial, or request for more information, it comes on a document from the insurer. For ease of demonstration, I'm going to use the CMS language. Commercial insurers use slightly different language, but the information and intent are the same. So here we go. The insurer will send either an electronic remittance advice, ERA, or standard paper remit, SPR, with the payment arriving as an electronic funds transfer, or EFT, via automated clearinghouse, or ACH. If you're still with me, yay. If you've been around in revenue cycle as long as I have, you may know the remittance advice as an explanation of benefits, or EOB. Well, the EOB is now used exclusively for Medicare Part D prescription drug plans. The original Medicare Part B patients now receive a Medicare Summary Notice, or MSN, every 3 months. So welcome to the alphabet soup. Now that we've tackled the acronyms, let's go back to the revenue cycle and the billers. Okay, so if you're unfamiliar with the ERA, ask your billers to show you one, or you can go to your MAC website and view one. They all have one on there someplace. You may have to hunt for it a little bit. At the bottom of the ERA, there's a glossary of acronyms used for each claim line to provide additional information. The claim adjustment reason codes, also known as CARC, provide information about why the claim or the line item on the claim was not paid as it was billed. The remittance advice remark codes, also known as RARC, provide additional information to supplement the CARC. There's also claim adjustment group codes, typically just called group codes, that provide additional information for the CARC as well. These codes usually assign responsibility for the unpaid portion of the claim. So these codes are CO, which is a contractual obligation, and it assigns responsibility to the provider. CR is corrections and reversals. OA is other adjustment, which means that there's no other group code that's applicable. PI is a payer-initiated reduction, and PR is patient responsibility, which is the only time you can bill patients for the remaining portion because they've assigned the responsibility to the patient. So using the CARC, RARC, and group code information from the ERA allows you to determine the reason for the reduced or non-payment. This information is a wonderful starting point to analyze and correct your processes, which sometimes include people. Some of the issues could be data entry errors, improper diagnosis code, missing an MPI, missing an NCD code. Any of these. If the problem is missing inaccurate or incorrect information, you can correct it or add it and resubmit. Just remember, if you're amending documentation, do it appropriately. There are rules. Okay, so go through a couple examples to show you how the CARC and RARC and group codes work. So in this example, you have a CARC CO16, which states that the claim or service lacks information needed for adjudication. Additional information is supplied using remittance advice remark codes whenever appropriate. Apparently it's appropriate. So they give us a RARC MA27, which states missing invalid entitlement number or name shown on the claim. So armed with this information, you know the claim has an issue with either the name or the entitlement number or insurance ID, or both. So the claim can be resubmitted once the patient's information is corrected. Second example, you have a CARC CO97 that states the benefit for this service is included in the payment or allowance for another service or procedure that has already been adjudicated. The RARC attached is N525 that states these services are not covered when performed within the global period of another service. So this would indicate that you had a service billed in the global period. So unless there's a compelling reason why the claim should be paid separately, this information supports writing the claim off. If you believe that this service should be billed separately, then create your documentation to submit an appeal to the decision. Okay, always remember the remittance advice codes and remarks, no matter the insurer, all provide their version of CARC, RARC, and group codes. The information may indicate a request to review a chart note for an encounter by sending supporting documentation. Retina practices frequently get requests to provide a copy of the invoice for the drug that was on the claim so they can see how much the practice paid for that. Additional documentation requests are fairly straightforward, but if you miss them on your ERA, then you're not getting paid for something that's simple as sending in an invoice and they'll pay you them. Remember, your external components of the revenue cycle need management just as much as the internal. So it's vital to review and understand some seemingly random claim denials that don't make sense. And I have a couple of real life examples that on more than one occasion, an intravitreal injection, CPT code 67028, was denied as, quote, experimental and investigational, end quote. Really? How's the physician supposed to get the drug into the eye? Are they supposed to throw it at them? How is this experimental and investigational? Obviously, appeals and fighting and conversations and whatever, ultimately, we were paid. It wasn't the only time it happened, but randomly it would crop up. You know you should be paid for it, so you work at getting that appealed. You'll also see denials when you do bilateral injections on the same day. They pay one eye and deny the fellow eye as a duplicate. Again, seriously. So you appeal, use chart documentation, use arrows and circles, and point out what it is supporting your service that should be paid. Ultimately, if you don't read the remittance advice, you're not going to find some of this information. And some denials are appropriate and were pure billing mistakes, or somebody didn't know the rules, or it was an oops factor. An example for that is billing an office visit in the global post-op without proper indication. Proper indication means that that office visit needs to be unrelated to and not a complication of the prior surgery to submit the claim. So if it was inappropriately billed, you would write it off and you would educate and provide feedback concerning these errors and mistakes to reduce the number of claim denials and silly things that you don't need to deal with that are just, they shouldn't have happened in the first place. So whether the information comes from the biller, the clearinghouse, or the insurance carrier, I can't stress enough how important educating the staff about the process and what it takes to rework a claim And for your providers, sometimes if they're part of the problem, sharing with them how much time and the financial cost of reworking a claim will get their attention of how much wasted money is going out the door because they didn't just do it right in the first place. Ideally, everyone does their part for clean claim submission, which means you get a timely payment from the insurance company and hopefully from the patient as well. The reality is people are not perfect. Mistakes will happen. Even with excellent electronic options with insurance verification and EHRs and electronic claim submission, you will have errors. The key is to reduce the number of mistakes using the information and education to improve your revenue cycle. Remember, you're looking for well-run, not perfect. Okay, so every industry has key performance indicators or KPIs that determine how your business is doing against the industry. And most KPIs provide information for operations or for finance. KPIs are also frequently called benchmarks. And the ones that I will cover today measure effectiveness and efficiency of the revenue cycle. Using industry benchmarks assists you to know where you stand relative to your peers. Also, knowing your payer mix of original Medicare, Medicare Advantage, Medicaid, commercial, work comp, self-pay is significant in getting your overall picture of the revenue cycle and the health of it. So retina practices, pediatrics, neuro-ophthalmology, and oculoplastics are usually outliers to ophthalmology as a whole, 0-18. Since we'll review some of the key performance indicators for the revenue cycle, in this case today, the subspecialty will not play a significant role. There are some that it will. All right, so here's a laundry list of KPIs. This is just a smattering. This is a sample. This is not exhaustive. And each of these will give you some piece of information about the health of your revenue cycle. So you have your basic accounts receivable or your AR, your days in AR, aged AR, AR over 120, total AR over 120. Two of my favorites that aren't on here is your service AR over 120 and your drug AR over 120. When you separate them, you can see different pictures. You have your days sales outstanding, your gross collection rate, net collection rate. All of these provide valuable information. And using the benchmark percentages will help you know where you are in the revenue cycle and how well it's doing and where you need to focus attention. If you're within the benchmark, usually you're okay. However, remember some of the subspecialties will be outliers no matter what. So neuro-ophthalmology can be an outlier on office visits on the low side due to the length of time it takes for testing and exam. And retina, on the other end, can be an outlier because they do so many intravitreal injections without a concomitant office visit that they don't count as traditional E&M or I-code visits, so your patient volume. So they look odd compared to general ophthalmology. So if you're an outlier, it's important to understand why. An outlier doesn't mean bad, it just means you're different, but you need to understand, don't ignore the information, and understand the metric and what that means to your practice. Okay, whoops, I jumped ahead, my bad. And now I'm having issues. So we're gonna go along with this. Okay. So the KPIs that I wanna touch on are the last four on this slide. Your charge entry lag, your bill charge lag, your claim rate, your claim denial or claim error rate. It's known as both. And I feel like sometimes these are overlooked because everybody's looking at your AR and all of these other things, that these are really simple metrics to make a well-run revenue cycle. Okay, so now we're going to jump forward and we have first your charge entry lag, which is the metric that indicates efficiency in charge capture. It affects your total days in AR, and it's defined as the days between your date of service and when the charge is entered. Industry benchmark is 1 to 3 days. As an aside, always run your reports from the date of service, not the date of entry. The date of service starts the clock ticking for insurance companies, so it's best to use that date when you're doing these metrics because you're working with the insurance company timeline. So you can experience charge entry lag in a couple of ways. If your providers personally enter their charges, then you can have a charge entry lag when they've seen the patient and they haven't entered their charges. Some EHR systems won't allow the charges to show as billed until the provider signed off on the chart note. So ensuring that your provider completes their documentation on the date of service is essential, especially with some of the changes coming in January. Another scenario is if the provider marks charges on a fee slip or a routing slip, some piece of paper that follows the patient around, and then staff enter the billing codes. So the person entering the charges could be at the front desk, they could be in the billing department, but either way, there's a lag created if those charges don't get entered. If your lag is over 3 days, you really need to figure out what's going on. If you have multiple providers who enter their own charges, look at the metric for each of them. Sometimes when you look at them in composite as a whole, you don't see the problem, and so pull them apart as individuals. And you may find that if you have 4 providers, 3 are really good about doing it and 1 is not so good. So then you need to explain to that provider what happens when they don't enter their charges. If somebody other than the provider enters the charges, then look at your process. What's the cause of the delay? Do you have satellite clinics that send the fee slips to the billing office to key the charges? What's the time lag from point A to point B? Do you have staff that are cross-trained to know how to enter the charges if the primary person is out of the office? So just look at your process to see where there's room for improvement. If staff work remotely, like they probably are during COVID, it's even more critical to review and find your best streamlined option to ensure charges are entered within the benchmark. If your charge entry lag already falls in the 2 to 3 day metric, you still have an opportunity to decrease your benchmark percentage in reviewing the process, because each day the charge isn't entered is another day added to your AR. So the next one is the billed charge lag, which is related to charge entry lag, but slightly different. The billed charge lag occurs when the providers enter the charges, but the biller hasn't pushed them out the door. So this metric also indicates efficiency in charge capture, and it does affect total days in AR. Easy to remember, it's also a 1 to 3 day benchmark. If your metric's higher than 3 days, you need to figure out why. There's some possible reasons. Maybe, as I said, you have a biller who's doing this and they're out of the office and nobody's cross-trained to take their place, in which case cross-training should be a top priority. Maybe your charge is on hold while you're waiting for information from the provider before sending the claim out. So ensuring that you run a hold report a minimum of once a week is suggested. However, if you can run a hold report every morning for the day before to make sure you know what you need to follow up on, that's even better. If you use, as with the charge entry lag, if you're using a runner tag or a fee slip, even if you're on EHR, getting those from satellite offices can be challenging. So you have the same problem with the entry as well as the bill to get them out the door, to keep your days in AR down. A lot of retina practices, including the one that I ran, use the fee slip to add documentation or stickers to from the intravitreal drugs. So the biller would confirm the drug charged is the same as the drug documented on the fee slip. And suppose you have an electronic inventory management system. In that case, the daily reconciliation report will catch an issue if one drug is logged in the inventory management system and a different drug is charged. Using your inventory management system as a check and balance for injectables is an excellent way to prevent a hiccup in your revenue cycle, such as billing for an incorrect drug or failing to bill for a drug at all, both of which are costly. If you have multiple providers and multiple locations, run the billed charge lag for each provider and each location. And you may find that you have one location or one provider that causes a problem, or it could be that provider going to certain locations cause a problem. There's a myriad of permutations and possibilities. So keep exploring those reports until you find the right mix of where you have a problem. Just as with the charge entry lag, making sure you have the best streamlined process is important. Both the charge entry lag and the billed charge lag are within the practice and the provider's control. So improving these 2 metrics can make a difference in the timeliness of receiving insurance payments this month versus next month. If you think about 1, 2, 3 days, that can make a huge difference. Okay, so the next one is a clean claim rate. And it's the number of claims that pass the edits the first time without intervention. And you get the calculation by the number of claims that passed the edits divided by the number of claims submitted. Your benchmark is 95% or better. So if you have lower than 95, 94, 90, 85, then you know you have errors. Actually, if you're at 95, you know you have errors, but it's in a 5% ratio that people consider acceptable. So you have to review your reports from your clearinghouse to see what are the mistakes that are stopping them from going out. It could be a date of birth mismatch, not having the male or female as the insurance does, and that happens especially with unisex names. The ID number could be missing, incorrect, or incomplete. And these data issues you will find on your clearinghouse report. In addition to reviewing the report, you need to use your remark codes, your advice reasons to determine your errors. And then once you put on your detective hat to trace the error to why they occurred, where they occurred, and who's responsible, then it's time to educate your staff about the error and the proper process to prevent reoccurrence. It is always more effective and meaningful to have the employee correct the mistake that made the mistake versus, oh, here's the mistake we found and we already fixed it. There's no impact. There's no muscle memory to doing it correctly. And I realize that during the pandemic, it may not be an option to do that. However, it's important to keep the information to use as training versus you're in trouble, my opinion. The mistakes and errors that you'll find usually fall into one of two categories. They're either consistent or they're inconsistent. Consistent mistakes are much easier to correct because it's a single thing. They do it every single time. I had a staff member who consistently would fail to put in the patient's new insurance. We had the old insurance in. They would get the card, make a copy of the card, do all the right protocol, and forget to key it in. So by the time it got to billing, it was an issue. So we found processes and reminders for that person to remember they had to enter it. The erratic and unpredictable errors that are all over the place are so much harder to fix. If you have a staff member that transposes numbers sometimes, doesn't put the insurance in sometimes, picks the wrong insurance pretty consistently. They always pick number 3 Anthem, not number 4 Anthem, and so forth. The inconsistency is just hard to fix. So now you have to look at it from a different route. Are they too busy? Are they not busy enough? Are they rushing? What else is going on that's causing this smattering of different kind of problems? Because remember, you're looking to have correct claims submitted the first time for an efficient revenue cycle. Well run, not perfect. Okay, the claim denial or claim error rate is the percentage of claims denied by the payer for a specific period. To calculate the rate, you take the number of claims denied and you divide by the number submitted for the same period. So that period can be a month, a quarter, a year, doesn't matter, just use your same start and end date for the metric. So it could be a week for all anybody cares, just use the same dates. The benchmark's 5 to 10%, but everybody wants 5%. It's lower, of course you do. But I believe that it is crucial to look at claim denials in two ways. So the first is a count of the number of denied claims out of the number submitted. And the second is the dollar amount of denied claims out of the dollar amount of claims submitted. And here's why. If you review the claim denial rate only as dollars and the dollars are low, you may believe everything's great. However, if you check the claim denial rate as a percentage of claims submitted, you may find a very different picture. So let's look at an example. So claim denial rate on the count of denied claims, you have 425 out of 7,200 that were submitted, you're at 6%. Awesome, you're in your goal, 5 to 10, yeah, 5's better, but 6 is great. This is not a problem area. However, when you look at your dollars, at 120,000 denied out of 1 million submitted, that's 12%. Woo, I've got a problem there. But you wouldn't have found it if you only looked at one. So here's another example. Denial count of 500 out of 3,600 is a 14% error rate. That's not good. But if you look at the dollars at 25,000 out of 500,000 submitted, it's only 5%. You hit your goal. The problem is that there could be many low dollar claims or a few high dollar claims. So if you only review one of the calculations, you may not have an issue. but when you will generate a much clearer picture if you look at both versions for your denied claims by count and by dollars. Both analyses provide incredible information. Your denials are going to be across CPT codes most likely, so get curious and ask questions. Dig around until you find out the issue. Is it a timely filing issue? Is it a particular CPT or HCPCS code that has consistent denials? Is it a specific payer that's consistently denying? Is it across all payers with particular codes? Is it one provider? Is it a provider that has different billing patterns from the other ones? There's so many possibilities and combinations that you just keep digging down into the cause of the denial. Once you understand the reason, determine if you need to appeal it or if you write it off. Either way, you may need to educate staff and the providers to reduce or eliminate identical types of denials. So I'm breaking down the denial types into categories, and putting them into buckets is a good way to not only review and find a pattern, but it's a good way then to provide education and feedback. So you could have a registration bucket, a coding bucket, a billing bucket, and kind of a general training bucket. And as you classify the types of denials or problems, you throw them in those buckets so you know who you need to address, and whether it's across the board, you need to get everybody in the same room and go, here's the revenue cycle and here's how it works. And here's where everybody is a cog in this process and we're all intermixed. Or you go, this particular section has this problem, let's get it fixed. Let's figure out what's going on and let's get it fixed. So examples of registration issues can be inaccurate, incorrect, incomplete, whether it's patient demographics, a home address, a phone number, all of those lovely little items that will just mess you up from the get-go. Coding examples could be a provider or a scribe, depending on if you have scribes as well, selecting an incorrect CPT code or HCPCS code or or selecting an ICD-10 code that doesn't have specificity, like it says no I, so it's neither I, and misusing modifiers. Some billing examples might be to forget to include the referral number, authorization number, fail to put an NDC code on the drug, or to miskey a CPT or ICD-10 code if you're hand keying versus entering from an EHR system. Using the training bucket for denial reasons for more general education is kind of what every now and then I would do, probably once a quarter. That was the meeting. We're going to talk about everybody's role in this to cut down on the us and them, especially when the billing department was finding more issues. If you find that an issue falls to an exclusive department, then that's where it needs to be addressed. Okay, so I've just gone through a ton of information, including the 4 KPIs we discussed more in length, which were the charge entry lag and the bill charge lag, your clean claim rate, and your claim denial or claim error rate. Each of these are an essential piece of evaluating the revenue cycle and the health. They can tell you a great deal of what's happening in the practice. And when reviewing your KPIs for your practice, figure out which of these fall in the benchmark and out of the benchmark. And once you identify that, then start working on what needs attention and what comes first. So if you had a charge entry lag that's really bad and you've looked at everything and this is the system and there is no alternative, sometimes asking people for suggestions, especially your staff, they have some interesting ideas that shouldn't necessarily be dismissed. They might actually work. But if you can't change it, then where's your next problem? If you build charge lag, get creative. Think outside the box. Try things that are kind of crazy. Sometimes that's what works. It's just vital to always keep track of these, no matter what, even in this exceptional year of 2020. And I believe that when you focus on anything, then you're going to pay attention to it. You're going to improve it. And if you do that, your revenue cycle will get better the more attention you pay to it. Remember, you're not striving for perfection. You are striving for a well-run, and that is a very achievable goal. All right, so end poll. So Doug, if you'll throw up the second poll, So after this webinar, I believe I can perform a high-level revenue cycle assessment, determine the impact the revenue cycle is having on cash flow, identify areas that need attention and prioritize them, or all of the above. Let's see where we are. Do we have results yet, Doug? Yay. Okay, very good. Good to know. All righty. So we'll close that. So I want to thank everybody for attending the webinar today on how long since your last revenue cycle checkup. And I also want to especially thank ArbiMed and Notal Vision for their support of the presentation. So I believe we have some time left that we can answer some questions if we have any.
Thank you, Elizabeth. Yes, please submit any questions that you may have. We will hopefully have time to get to them here today, or if not, we can follow up with you personally. Elizabeth, we did have some questions come in prior to the webinar. One of them here is, our receptionists often make mistakes, but our biller fixes everything because she says she doesn't have time to make copies, explain the error, and let them fix it. Do you have any suggestions for getting them to stop making these mistakes?
I alluded to it in the webinar with the education. So one of the things that we did was, if we had somebody in particular making a lot of mistakes, is we'd have them sit with the primary biller who did the keying, pushing out, reviewing to make sure that everything was correct before it went and the drugs matched and all of that. Had them sit with them for half a day, especially using when they had a batch from a clinic that receptionist had been in the day before. So they saw the errors, they saw what had to happen, they saw the extra work, and they got an idea of why on earth the biller would complain about all of these little things that they didn't mean anything to her until she saw it, and her performance improved tremendously, and understanding the impact of the little things if somebody else will catch it. So that, and it's hard right now in pandemic, but maybe there's some creative options to do that. But once things get a little more back to normal, I highly suggest having people sit with the biller that does that and understand the impact. That's a good question.
Thank you. We've got a question here from Pedro, who's actually who works with us here at is an ArbiMed customer. And I think, Elizabeth, that's not so much specific to ArbiMed. We maybe can follow up with Pedro after, but specific to inventory management and any software programs that you use. Pedro's question is, what are your best practices, and what do you suggest as far as what reports to run and how often when it comes to maybe your inventory management software or practice management software? What reports did you find helpful from those programs or systems?
There was and every system has its own name for these reports, but basically, the first thing in the morning, there was a report that we pulled down that showed all the drug charges from the day before. So it was the drugs that were in the system that were assigned to a patient, and then the drugs that showed in the practice management system, and the two should marry up. If they didn't marry up, then it had an error. They showed up on this report that needed to be fixed. And it could be that the eye was incorrect, that one said right eye, one said left eye. It could be that one said OU and one said right eye. It could be that it was one drug A, and the other was drug B. So now we had to go back, and that's where we had the piece of paper that ran through that would have the sticker on it that showed we knew what the drug was. What in theory it should have been. So then it's going back through documentation. So every morning that was run. And when the biller then pushed the charge out the door and it was fixed, it should fall off the report the next morning. So every morning that was reviewed. It's essential to make sure, especially if you're a retina practice and you do injections at all. If you're an anterior practice that doesn't do injections as much, any day that you're doing injections, I highly recommend looking at it the next morning, to make sure, or even that afternoon, to make sure that your charges captured, from the inventory management system match what has been keyed in for the practice management system.
Wonderful. One other question that came in. We have satellite clinics and the fee slips used to come back to the main office for the biller to key in the charges. With COVID, we are limiting staff traveling from one clinic to another, so it takes almost a week for our charges to get entered and billed. Do you have any suggestions to make this process better?
Um, the first thing that comes to mind is, do you have a scanner in your satellite office where the documents can be scanned into a repository that's HIPAA compliant? So they can still come back however they normally physically come back, but the satellite could scan in all the documentation for the day. So the biller has it and can go ahead and start processing the claims to get them keyed in and pushed out, verified, whatever the process is. But so you don't have that lag in getting them out the door. Scanners, usually a lot of fax machines are also scanners. A lot of printers are also scanners too. So there may be a really good option that you already have in a house that you may just need to ask your IT about how to utilize that best. But still have the hard copies come back.
Wonderful. As of right now, I'm not seeing any other questions. Thank you so much. We want to thank you for taking the time and putting this together. Um, our contact information here is on the last slide for all of us who were involved today. There will be a recording available probably after the holiday. We will forward it to everyone who joined us here today. And if you felt the presentation was valuable, please share it with your friends in the retina community and let them know that they will be able to access this webinar after the fact. But again, I think we're going to hold off until after Thanksgiving to start putting that recording out. So please feel free to reach out to any of us personally if you have any questions about today or any of the companies here, ArbiMed, Notal Vision, etc. Elizabeth, thank you so much. Fantastic job. Thank you everyone for joining us here today.
Hey,
And we
Doug.
look, yeah, go ahead.
Hey, this is Kyle with ArbiMed. I just wanted to chime in and say we also do plan to do plenty more webinars on a variety of different topics. So if any of you have some suggestions or any ideas of what you think you would like to learn more about, we would be happy to put that in our plans. And again, thank you very much, Doug and Elizabeth, for getting this all together, and Chris as well. Thank you.
Yes, absolutely. If anyone has suggestions for topics that they'd like us to cover, please let us know. We'll be happy to try to get folks to participate, and we definitely plan on having Elizabeth back to speak on another topic. But we'd like that topic to come from the audience. So, thank you again, everyone. Have a wonderful holiday. And again, if you have any questions or you want to get a hold of us individually, please feel free to do so. Have a great day. Thank you.
Thank you.